Welcome to AETCM, the emergency medicine channel. Shall we start? A 28-year-old male came to ER with complaints of actively coughing blood in sputum since today morning. On initial 10-second assessment, airway was initially patent, but since patient was actively coughing blood due to risk of potential blood aspiration, suction was applied. Cough suppressants, codeine syrup 10 to 20 mg was given to the patient. Nebulization with tranexamic acid 500 mg Tranexa diluted in 3 to 5 ml NS was given to the patient, and preparation and arrangement for intubation was done. Coming to breathing, respiratory rate was 25 rate per minute. SpO2 was 95% in room air. We provided 2 liters of oxygen via nasal prongs. On auscultation, bilateral basal crux was present. Coming to circulation, BP was 110/80, heart rate 98 beats per minute. Capillary refill time was less than 3 seconds. 2 large IV bore cannula was placed. Coming to disability, GCS was E4V5M6, GRBS 108 mg per DL. On exposure, patient was febrile. Coming to adjuvants to primary survey, we took an ABG showing pH of 7.4, PCO2 of 30.3, PO2 of 71, potassium was 4.2, sodium 139, creat was 5.6 and lactate 1.2.
Creat was 5.6. Okay.
Coming to CBC CRP, total count was 9.6, HB 8.9, platelet 185, CRP was 10.8. ECG showed normal sinus rhythm. Coming to ample history, a 28-year-old male came to ER with complaints of cough with sputum containing blood since today morning. Patient had noticed mild streak of blood in sputum since last 2 days, but today it progressed and he had lost around 100 to 200 ml of blood in sputum. No history of fever, chest pain, weight loss or any previous history of hemoptysis. A patient is not on any anticoagulants or antiplatelets.
Why is creatinine is 5?
Patient is a known case of Alport syndrome.
Alport syndrome.
With renal dysfunction and baseline creat of 5.1, on maintenance dialysis 3/7.
Any renal diseases that can cause hemoptysis?
Goodpasture syndrome.
Goodpasture syndrome is common to cause hemoptysis as such. Okay.
Alport is very rare, only in X-linked. Patient is also on tab arcamin clonidine alpha 2 agonist 100 mg TID and tab nicardia nifedipine 20 mg TID. No known allergies. Last meal was today morning 9 a.m.
Any drugs that can cause therapeutic drugs that can cause hemoptysis?
Therapeutic drugs.
Any antihypertensive that can cause hemoptysis? Hydralazine. Hydralazine can cause hydrolysis-induced vasculitis. Can cause hemoptysis. Very rare, and rarely it causes significant enough hemoptysis. Usually it is very mild hemoptysis as such.
After providing patient with Tranexa, cough suppressants and oxygen, patient did not have any further episodes of hemoptysis. We took an chest X-ray, PA, which showed bilaterally patchy infiltrates. Then we had sent the further labs and investigations. PT-INR was sent. It was under normal limits. RFT creat was 5.9 mg per DL. Urea was 71. We had also sent anti-GBM antibodies to rule out any coexisting Goodpasture syndrome with Alport's.
Okay. Anyhow, fine. So you got a 28-year-old male patient presenting with a hemoptysis. So how are you going to approach this case? What is the primary, management is there, management will come later. What is your primary question to the patient?
Primary, we have to rule out whether it's an hemoptysis or pseudo-hemoptysis.
No, okay, good. So whether you want to know where the blood is coming from, how will you know that? What are the questions that you can ask which will help you identify pseudo-hemoptysis?
If hemoptysis, we are suspecting hemoptysis, usually it will be sputum tinged with blood. If you are suspecting upper GI bleed, then patient will have vomitus with blood, not sputum.
Cough with the sputum or spitting out of blood is usually hemoptysis, and vomiting out blood is hemoptysis. Very easy thing is, are you coughing out blood or spitting out blood, or are you vomiting blood?
Vomiting
will be the easiest thing to ask. One thing you have to rule out is postnasal drip.
Postnasal.
Patient can still say I am spitting out blood when the blood is coming from postnasally. So that part you have to clear from the patient. This is the history wise, this is the question that you are going to ask. From where are you spitting out? What is the next question?
How much ml of blood?
Yes. Quantification of hemoptysis is important. Why is it important?
We have to categorize accordingly,
As?
minor, moderate and massive.
Yes.
If minor is less than 30 ml in 24 hours, moderate is 30 to 100 ml, major is any 100 to 1000 ml causing airway obstruction or hemodynamic instability.
So hemoptysis is basically mild, moderate and means massive hemoptysis. So problem with the massive hemoptysis is there is no recognized definition of massive hemoptysis. Some books say it is more than 650 ml. Some books say more than 800 ml. Some books say if patient is having hemodynamic instability, it is massive. Quantity doesn't matter. Some books say more than even 150. So there is no unified definition, because since it is not unified definition, your idea of massive hemoptysis should be any hemoptysis that is significant enough to obscure the airway of patient. That is, patient is continuously coughing or spitting out blood, that even after doing that, patient's airway is getting occluded due to blood. That is continuous bleeding from trachea. So basically patient is doing what? Patient is aspirating and patient is not able to breathe. There is a airway obstruction going on. So any hemoptysis that can cause airway obstruction is massive. Any hemoptysis that can cause
Clot.
ventilatory dysfunction. That means patient's hemoptysis is so massive that it is disrupting gas exchange, causing hypoxia to the patient, or hypercapnia. Hypoxia is the easiest thing that you can see. Hypoxia to the patient, you can say that is massive. Or third is the one, third is this thing, or any hemoptysis, massive hemodynamic instability. So these are the easiest ways in which you can say patient is having massive hemoptysis, because volume is very disproportionate. Patient can usually overestimate their blood loss. Patient may say I have vomited out half a liter, while he might have only vomited out significantly low. Because of that gross misproportionation, we can't believe on the volume, but look for these signs of this thing. Okay, so that is your next part. Okay, then how are you going to evaluate?
According to either if the patient is having moderate or mild or massive. If moderate or mild, we can give symptomatic treatment like
No. Treatment will come later, because at the end of the day, hemoptysis treatment in ER is very straightforward. It's one of the straightforward management that you can do in ER, and that management is pure ABCD management. It has nothing to do with patients' underlying diseases. But if we say that management, then the entire discussion will not come. That's why I am asking, so you got this much, you got the volume, you got to see whether it's massive or not, and now you want to know why he is bleeding, right? So what are the causes of hemoptysis?
It is divided into 4-5 categories. It can be either infections, causing disruptions or neovascularization causing bleeding, like chronic bronchitis, bronchiectasis. COPD also can cause, or it can be a mass eroding into the blood vessels and causing bronchogenic carcinoma, or it can be a sequel of tuberculosis causing cavitatory lesion or aneurysm, again causing bleeding, or it can be a vasculitis causing alveolar damage and bleeding can happen from that. So infection, it can be bronchitis, tuberculosis, or any fungal aspergillosis. Coming to cardiovascular causes, it can be pulmonary edema, it can be chronic congestive heart failure. Coming to vasculitis, it can be Goodpasture syndrome or vaginous granulomatosis.
Okay. Truly, whatever you told is correct only. In this, what we want to understand is lung, like liver, has two blood supplies. Okay, that's very important. So when a patient with hemoptysis come to you, you have to understand what blood supply am I dealing with. The question is that which blood supply is the one that is bleeding. So what are the blood supply to lung? You have
Bronchial and pulmonary.
bronchial arteries and pulmonary arteries. What's the difference between bronchial artery and pulmonary artery blood supply?
99% is done by pulmonary artery.
Bronchial artery blood supply is for endobronchial tree. That's why it is called bronchial artery blood supply. It's an endobronchial tree. Trachea, bronchus, bronchial generations. That's what endobronchial artery supplies. So the supply of bronchial artery is very minimal. The total blood supply to lungs and the supply done by bronchial artery is very minimal. The majority of lung circulation is done by pulmonary artery. Okay. So that's two things. But what is the main difference between pulmonary artery blood supply and bronchial artery blood supply?
But
Tell. Correct. Massive hemoptysis are usually bronchial artery origin. Why? Why not pulmonary artery? 99% of lung, not 99, but more than 90% we can safely say. More than 90% of lung circulation is by pulmonary artery. Then why only bronchial artery is having massive hemoptysis?
they are more fragile.
Bronchial artery is systemic circulation. It's a high pressure circulation. Bronchial artery is originating from aorta, isn't it? Pulmonary artery is from right ventricle. So it's a low pressure circulation. Since low pressure circulation, bleeding, most common bleeding manifestations in the lung can be from pulmonary artery origin, but it rarely causes massive hemoptysis because the flow or pressure is that much low. Okay, so when you are dealing with a massive hemoptysis, like when we told hemodynamic instability or continuous bleeding and all, you should think, okay, I might be dealing with a bronchial artery bleeding rather than a pulmonary artery bleeding. There can be other reasons for this also. We'll come to that, but this is one thing that can make you understand, okay, this is not something that I can play with. You need much more aggressive management, and you have to make ready the patient for definitive management. Pulmonary artery hemorrhage, we can wait and watch. Bronchial artery hemorrhages, you need definitive management. Okay, that is another thing. Now, when you say, once we say this, now the causes of hemoptysis should be divided into like this: bronchial artery involved cases, pulmonary artery involved cases. Got it. So whatever you told, we can categorize like this. So anything that affects bronchial artery will come in one section. So that comes as your acute bronchitis. Acute and chronic bronchitis can cause hemoptysis, but usually acute bronchitis causes acute hemoptysis, which can be a quite significant amount of hemoptysis can happen, but that's usually in acute bronchitis. So acute bronchitis means ongoing infection. So infection history with the new onset hemoptysis with previous histories or similar episodes, acute bronchitis should be suspected. Most common is viral in origin. Now you have bronchiectasis, isn't it? Most commonly bronchiectasis, cystic fibrosis induced bronchiectasis. But bronchiectasis can cause significant hemorrhages. Why? Because bronchiectasis causes bronchial artery to dilate and become tortuous. Since dilate tortuous, once bleeding occurs, since high pressure system, patient will bleed notoriously. So one of the most common causes of mortality due to bronchial artery hemorrhages is due to bronchiectasis. Especially in our part of country where bronchiectasis is very common, we should suspect that. Okay. Now, bronchitis, acute and chronic bronchitis chronic bronchiectasis. More than acute bronchiectasis, chronic bronchiectasis causes more massive hemoptysis. Then bronchial, endobronchial origin malignancies and all. So what endobronchial metastatic malignancy from CA breast and all, metastatic malignancy to endobronchial tree, erode into artery and cause bleeding. Foreign body in bronchus. The patient has aspirated something and it is a metallic object or something. Now that is causing local erosion and causing. It can be due to this thing, bronchial carcinoid, bronchial angiolipomas, angiomyomas, all those things. So, but basically vascular complications of the endovascular tree. This is what in this thing. Now pulmonary. Now pulmonary is huge areas of causes are there. So pulmonary parenchyma is there and pulmonary vasculature is there. Pulmonary parenchyma is what? Pneumonia. Most common is pneumonia. Commonly is necrotizing pneumonia and lung abscess. Necrotizing pneumonia, lung abscess is the most common. Then what you have? Then you have your good posture syndrome. Then another one is there, no?
Vaginous
granulomatosis, Betches disease. All those comes in autoimmune conditions itself, but we can put it in parenchyma because it affects parenchyma. But autoimmune conditions, AV malformations, that comes in vasculature. So rheumatoid, SLE, APLA, SLE, APLA comes in parenchymal bleeding. So this is usually parenchyma. Then you have pulmonary vasculature complication. What are pulmonary vasculature complications?
Due to back pressure from.
That is your cardiac pulmonary. Due to back pressure, patient is developing hemoptysis, cardiogenic pulmonary edema. Then what is one thing that you will look for all breathing difficulty patients in ER? People will be looking for that condition. No? ECG, tachycardia, will do echo to look for pulmonary embolism. Pulmonary artery embolism, thrombosis of pulmonary artery, pulmonary artery AV malformations, pulmonary artery fistulas, all these things can happen. This is pulmonary artery vasculature. Then there are common conditions. Common conditions are very simple. All bleeding conditions. All condition bleeding, that predisposed patient for bleeding comes under that. Then systemic diseases. Side effect of systemic diseases. What is one? Toxin that can cause
cocaine.
Cocaine cause hemoptysis. Then we told drugs, hydralazine can cause, vasculitis can cause. This is the major classification. So why we told this is, as we just seeing, most common is pulmonary artery vasculature. Lot of things to rule out. But usually we will have a lot of time to rule it out also. In bronchial artery, very little things, only around 4 to 5 things are there to rule out, but you may not get time to do it. Okay. So these are the common. What are the common clinical findings?
Depending
How will patient come? Patient will come and say that I am spitting out blood, I am coughing out blood, sudden onset or progressively increasing. I waited for 1 day or after 12 hours and it's not improving. This will be the chronic. What in history should you ask?
If we are suspecting acute causes like acute bronchitis, we have to ask for fever history. And
so infection history you should ask. That will point towards bronchitis, bronchiectasis, isn't it? Then
if a patient is having any long-term history of weight loss and recurrent cough, we can rule it out both tuberculosis and metastasis.
Nighttime sweats, nighttime fever, weight loss. In India, you should suspect TB. Any weight loss without fever, with persistent vomiting, new onset vomiting, persistent cough, smoking history, you should suspect carcinomas. Okay,
then any history of a patient is taking any anticoagulants or antiplatelets or bleeding diastasis should be asked.
Bleeding, risk factors that causes spontaneous bleeding should be ruled out. Then any history of loss of consciousness, syncope, pulmonary embolism. Any acute breathing difficulty, pulmonary embolism, cardiogenic pulmonary edema, any ongoing chest
Chest
pain to
pain.
rule out MI as a cause of cardiogenic pulmonary edema, are those histories which is secondary you need to ask. Any previous history of similar complaints which will again point towards bronchiectasis, bronchitis, pulmonary TB, any history of TB, earlier treated TB, all those things can be ruled out. Okay, any females especially, whether SLE features, APLA features is there or not should be asked. Okay, so these are the major in history questions that you will ask. What are the clinical signs you will look for?
To look for hemodynamic instability, we have to see whether the patient is having tachycardia, hypotension, capillary refilling time. No?
Yeah. So first and foremost, once we come to clinical sign, we are going to ABC. Now, ER management. So first and foremost, as you told, is airway. Whether patient's airway is protected or not. So if patient cannot control the bleeding or patient is continuously bleeding out, it is always better to intubate the patient. But if there is no continuous bleeding, intubation should be avoided. Okay, the idea is we think is what, oh, patient is research, we need to intubate. That should not be done in acute hemoptysis. I am not saying do not intubate. What I am saying is, if we know where he is bleeding from, then intubation is not an issue. But if we don't know where he is bleeding, for example, we know he had a right-sided TB earlier. So most probably he is bleeding from right side. Those patients, even if you intubate, our management can still happen. But if you don't know the source of bleeding and you intubate, only way to identify the source of bleeding is either go for radio imaging or go for bronchoscopy. So if you are going to intubate, you have to intubate using
bigger size tube, so that
bigger size tubes. So 8 and above. So at least 8 size tube should be put into. So irrespective of females or males, you are going to put 8 size and above, because once you put bronchoscope, some amount of air passage should be there. So bronchoscope requires at least 8 size tube to comfortably enter into. So bigger use of ET tube should be taken. Then
if you already know the cause of, then we can intubate to that side of.
Yeah. So single, as I showed, if you already know from where bleeding is there, you can use side, specific side preferred single intubation tubes, ET tubes, single side intubation ET tube. So there is a left sided single side intubation ET tube and there is a right side single side intubation ET tube. You can take a left side and twist it and put it up. But basic idea is there is 2 lumens there. One lumen is connected to our cuff and another lumen is connected to a different cuff, and the lumen is extended. So extension can be towards rightward or can be towards leftward. So leftward is left sided and rightward is right sided. So you intubate inserting the extended limb deep into the affected trachea, and there is a cuff in that lumen. There is a second cuff around the double lumen. Okay, so inflate the first bronchial cuff so that whatever blood products are there, it won't spill into trachea and to other sides. So this is a lung protective intubation technique. But to know that, you should know where the bleeding is happening. So previous history of bleeding site will help you in this. So this is your intubation and bleeding. While intubating, you should use preferably bronchodilatory agents. You told me. What did you say?
Bigger size.
Bigger size bronchodilatory agents like ketamine. If at all possible in your center, you can go for awake intubation, which will be really good. If not, ketamine and fast RSI, rapid sequence intubation, rather than DSI should be done for these patients. So that is airway compromise. Now, if airway compromise is not there, we should try our level best not to intubate on the first chance. We should try to improve patients' oxygenation or patients' bleeding, reduce the bleeding tendency before trying intubation. Okay. Now, how can you do that?
First, we can give cough suppressants to reduce the
Good.
cough.
Usually cough will worsen ongoing hemoptysis, so cough suppressants. Okay.
Nebulization with the tranexamic acid or other vasoconstrictive agents can be used to reduce the bleeding.
Yes.
Every 4-6 hours.
Yeah. So tranexamic acid, nebulized tranexamic acid is shown. Some studies only, not much, but some observational case reports as well as studies have shown that tranexamic acid in comparison to nebulized saline, nebulized tranexamic acid has better effect in mortality and morbidity. So tranexamic acid nebulization you can give 500 mg to dilute to a maximum volume of around 5 to 6 ml. You can give it as nebulization. Every systemly you can give. If patient doesn't have any contraindication in massive hemoptysis, you can even give as IV, 1 gram tranexamic acid IV over 30 minutes slowly you can give. So that is the role of antifibrinolytic role. Then what can you do? You can look for any features of vasoconstriction. Okay. What are the vasoconstrictive agents you can use?
Epinephrine.
Nebulized epinephrine can be given if at all with tranexamic acid also bleeding not controlling. Epinephrine can be given as a last ditch method. What else? Look for bleeding problems. If bleeding problems are there, for as simple as that, the patient is on antiplatelets, aspirin, clopidogrel. What can you do? You can give platelets. Pooled platelets can be given. Or if patient is having severe thrombocytopenia, less than 50,000, pooled platelets should be given for the patient to improve the clotting mechanism. If patient is on oral anticoagulants, warfarin, what is the thing that you will give? What will you give?
By cryoprecipitate or what?
No, cryoprecipitate, but FFP. Easiest thing is FFP. Don't wait for vitamin K, give FFP for reversal of warfarin. Reversal of warfarin conditions. Then what? Or other oral anticoagulants are there. If you have reversal agents, you can use the reversal agents for that. Then what can you do? Look for factor 8 deficiencies and all. If that deficiency is there, cryoprecipitate we can give, but what do you actually give for factor 8 deficiency? Factor 8 concentrate you can arrange and give it to the patient. So that is bleeding conditions. What else can you do?
If patient is having hemodynamic instability, then we'll have to give
for airway,
flexible and rigid bronchoscopy.
No, that is for definitive management. If you know where the patient is bleeding from and patient can tolerate positioning, the patient should be kept in affected lung dependent position. You know that patient is having a fungal cavity on the left side or right side TB cavity is there. Patient is having hemoptysis. The affected side should be kept towards the gravity,
so that the blood will not come from
to the other side. So this is not to control the bleeding at all. This is to kind of prevent spillage into the other lung, causing compromise of gas exchange. Okay, that can be done. Now this is airway, right? What about breathing? Patient is having hypoxia. What will you do?
Oxygen via, depending on the saturation.
You will start on oxygenation. You can start on nasal cannula, you can start on face mask, but patient is still desaturating. Patient is 80-85% on room air.
NRBM can.
You can start on NRBM, fine, but
high flow nasal cannula.
High flow nasal cannula. But what about NIV?
NIV can increase the pressure and bleeding.
NIV should not be used for hemoptysis patients. Usually hemoptysis patients will be agitated, so there can be asynchrony. Patient will require constant removal of BiPAP to spit out blood. So, or patient can aspirate on the same blood. So that complication, and it will cause intrathoracic bleeding, increase intrathoracic bleeding by increase in the thoracic pressure. So NIV is absolute contraindication for hemoptysis, ongoing hemoptysis patients. So it's oxygenation. You have different methods, as she told: nasal cannula, face mask, NRBM. If needed, high flow High flow nasal cannula itself you can give. When you give high flow nasal cannula, patient's oxygenation can be improved with increase in flow. Not FiO2, more than FiO2 flow can be increased. Up to 60 to 80 liter per minute flow we can start off in those conditions. Okay. And if all this fails, then only you should go for intubation. Okay, that we have already covered. So suctioning in any patient whom you are managing conservatively, that is with oxygen, with as you told, vasoactive agents or with tranexamic acid, patient may still be coughing out blood, so you are given cough suppressant. In the meantime, give regular suctioning so that patient may not have that much difficulty in maintaining airway. Now, what about hemodynamic instability? Patient is having hypotension.
Hypertension,
what to do then?
tachycardia. Then first we will have to provide the patient with IV crystalloids.
Okay. First is IV crystalloids. Second is?
Arrange for PRBC as soon as
so
possible.
you treat it like hemorrhagic shock. Avoid in all ways to start on pressors. The pressors, vasopressors or vasoactive agent should be the last thing in your menu. So any patient who is having hypertension, treat it like any hemorrhagic shock. Crystalloids as primary, followed by blood as soon as possible, and give blood. If it is massive hemoptysis with hemodynamic instability, you may even have to give in 1:1. Okay, so that is the management of shock as such, and inotropes should be your last mode of management. Okay, what else? Definitive management. Okay, what is the definitive management for any hemoptysis patient? Massive hemoptysis, right?
Suspect.
Mild is basically admit conservative management, tranexamic acid nebulizations, and admit to ward and evaluate with the radio imaging, right? So what is massive?
Massive. 100 to 1000 ml.
No,
massive.
what is the definitive management of massive?
Emergency bronchoscopy has to be done.
Yes,
Either
bedside
tamponade or-
bronchoscopy is the most important treatment modality that should be done. What are the goals you are trying to achieve?
With that we can do, it is both therapeutic and diagnostic. We can
Yes.
find out the cause and then we can do either arterial embolization or tamponade if it can be.
Yeah. Tamponade if it is from the endobronchial tree. Yeah. So bronchoscope you have majorly 2-3 goals. The main goal is to know from which side of the lung it is bleeding. So bronchoscopy should be advised for any patient who is not hemodynamically unstable. So if patient can maintain the airway and there is no significant desaturation, patient should be undergoing bedside bronchoscopy without intubation. That's why I told awake procedures can be benefiting for the patient.
So but rigid can be done without?
Rigid will be very difficult. The idea of rigid versus flexible bronchoscopy, the advantage of rigid is more suction power. So if you are going to give suctioning, clot removal and all, rigid bronchoscopy. But rigid bronchoscopy requires significant patient cooperation and position, which may not be always possible in an ongoing hemoptysis patient. So flexible bronchoscope is the bronchoscopy of choice. So idea is to give awake sedation to the patient. Dexmedetomidine or ketamine can be used for this, and go for a bronchoscope. Main idea is to identify, is it a bilateral thing or is it a unilateral thing. If it is a unilateral thing, identification of the site of bleeding is important, and if site of bleeding is identified, then you can think about a unilateral intubation, single lung ventilation by intubating in and closing off that side of the trachea. So better oxygenation you can maintain. A tamponade effect by the cuff can be provided. If at all, when the bronchoscope is introduced, if they can identify the source of bleeding, they can cauterize that area or identify whether the patient will benefit from interventional radiology. So this is the idea of bronchoscope. May not be always therapeutic, but diagnostic usage is pretty high. Once bronchoscopy is done, then we can go ahead for arterial embolization. So a pulmonary angiogram should be done to identify the source of bleeding, especially if it is unilateral, so that interventional radiology can try for a embolism of the bleeding artery. If it is bilateral or if a clear foci of bleeding is not identified, then patient should be planned for thoracotomy and control of bleeding by segmental arterial cauterization. This can lead to even lobectomy, but if patient is developing hemodynamic instability and your radio imaging doesn't identify the source of bleed, patient should be flagged for surgery. So the basic. So basically, in emergency room, the management of hemoptysis is very easy. Is it mild hemoptysis or is it a massive hemoptysis? Massive hemoptysis is obstructed airway or severe desaturation causing a gas exchange problem or hemodynamic instability. This is their plan for give crystalloids, arrange blood for emergency transfusions, plan for bedside bronchoscopy with awake sedation, and once bronchoscopy is done, either take a decision on intubating if it's unilateral bleeding, if it is bilateral bleeding, or if intubating on unilateral bleeding, or if bronchoscopy can do a cauterization, get it done. If patient requires intubation, intubate the patient ideally after bronchoscopy by doing a single leg ventilation, and then plan for radio imaging for embolization. If it is mild, still nebulization of tranexamic acid and observation in the ward, and plan for radio imaging on a better once patient is better or the next day. Okay. Anything else to add?